I call upon Dr. Anand Parthasarathy for our final talk on the multifocal IOL. So he's a cornea, refractive, and an amazing cataract surgeon in Chennai. So he's done his cornea work from Singapore. So sir is going to enlighten us with the multifocal IOLs.
Thank you so much for allowing me to be a part of the course. And I think the concept of multifocality between what Jayantan mentioned in contact lenses and what we find is actually quite nice. No financial interest, but it would be nice to have some. Okay, so there is one patient who I would present with business or government contracts, diagnosed to have cataracts in another hospital, and wants to read the Bible without glasses. Her children are doctors, son is a clinical trial specialist, and he's done intensive research on the different IOLs, including me. He's read all my papers published, has a discussion with me on my PCR rates and the number of premium IOL surgeries done. And the son discusses the average post-operative results, including the confidence intervals. The daughter wants to observe surgery, so she comes into the OT. Of course, the pre-operative preparation included antibiotics and NSAIDs for the patient, but for me, the preparation included prayers to Vishnu, Shiva, and of course Jesus. Luckily for both them and me, the surgery went off perfectly, and she did have a history of RK surgery. The brother also had similar surgeries done, and of course they didn't tell it, and the amount of refractive error prior to that was almost about minus 12 in both eyes, and they wanted spectacle free vision. Now if you can make out an RK surgery when you're looking, you need to make sure that the depth of the RK incisions are correctly looked at, and you need to plan your incisions. Most times you would end up with a scleral rather than a clear corneal incision. At the end of the day, the management were happy with the income, and I was happy with the outcome. Now, in terms of the uncorrected and best corrected, and you can make out in these patients also, you can actually get good vision. So these are post RK. We did a toric, multifocal toric. They actually did well. Remember, most of these patients are very smart. Most of them are very well read. All of them almost come well read in terms of their requirements. But we promise our patients sutureless surgery. We promise our patients painless surgery, and we request them for less post-operative time, but we need to make sure we are not paid less but more for these kind of surgeries. And perfect surgery is no longer utopian. Getting good vision 6 by 6 post surgery is quite well. So I changed the terminology to something called ATL, or advanced technology lenses, and I find that works better. It sounds a bit more different from what you would actually call them. This is the workflow at our clinic, where we have the questionnaire, we do have the consultation with the doctor and the optometrist, and we of course highlight the 99% success rate for surgery. An ideal patient is of course that you have good visual acuity. You can use limbal relaxing if you have access to it, and you remember that visual acuity is almost always enhanced by bilateral implantations. Now, what are the optical principles? Remember that the basic optical principle, because light is only 100% in, is to create a single elongated focus to enhance the depth of focus. That's how EDOF lenses work. Monofocal is basically a single point. Multifocal may have two or three discrete points. The main determinant of unwanted visual phenomena is the lens design and its optical parameters, and that is the basis for which you choose the lens. Remember, unfortunately, we cannot test drive the IOL with the patient. And there is a difference between EDOF and multifocal. EDOF available today are basically, some of them are really multifocal lenses with a lower near ad power, in which the rest of the power has been withdrawn to avoid the overlapping of the images. If you're looking at spherical operations, that's how EDOF works. There are multiple ways of modifying the central part of the IOL, which is the low ad, or you have small aperture IOLs. Now, this is a slightly busy slide, but I prefer to quantify EDOF lenses as pure EDOF, wherein you're moving around with the spherical aberrations, and hybrid, where these are basically trifocal with modifications or multifocal with modification. Now, there is some principal mechanism. There needs to be some high order aberrations, and this basically improves the depth of focus. And EDOF lenses, if you look at pure EDOF, the concept is modification of spherical aberrations. Now you look at the FDA data or the EDOF, and this is a slide, it's not very clear, but when you're playing around with this, you would lose a bit of contrast if you increase the spherical aberration, and that's an important factor. So if you want depth of focus, you will lose contrast sensitivity. And if you look at the package insert of this is from the VVT, it is very clearly written that these patients will have loss of contrast if you implant these lenses. So this needs to be clearly explained to the patient, and the company also accepts that. Now there is a different set of lenses which use a add just like a contact lens in the lower part of the IOL, and they also have seem to have good results. The concept is that if you're looking through the lower part, you would see reading, so the pupil tends to move inferiorly and nasally, and that's what gives you the ad. The ad varies from 1.25 to about 3. Now, what are the advantages of EDOF? Basically, the glare and the halos. If you think about a multifocal, you're looking about glare and halos. The amount of glare and halos are said to be photonic phenomena, said to be less with the EDOF lenses. This is an interesting concept where you have a central hole, and this is something that has now been actually accepted by the AccuFocus, which were making the presbyopic implants. And of course, the cutting edge is basically the trifocal optic, but these rings is something that are present on the surface of the IOL, which will affect with the light. Epithelial disease, I think Nishan touched about it, but remember that a lot of borderline OSDs like this, if you try and put a multifocal IOL, you will struggle with post-op results. So I prefer to do punctal plugs prior to surgery before I take them off. Just to conclude, there are basically characteristics. So if you're looking at multifocal, you're always going to get better near vision. If you're looking at EDOF, probably distant and intermediate good, which is about 50 to 70 centimeters. Near is not that great. Toric, of course, gives you very good distance vision. And monovision is basically, if you do a bit of mini or minor monovision, you will be able to manage reasonably range of distance. The SRKT preferable formula, the Holiday 2 if you have access to it. Remember, I prefer to aim for about 0.25 for the first eye and target about 0.5 for the dominant eye. And post-op evaluation, make sure that you refract them early, preferable to do a retinoscopy. Thank you so much.
Thank you so much, sir. Have you given a combination of EDOF in one eye and
There
the
is a trend
trifocal?
towards that, partly because if you get that multifocality of a +3 or +4, and then you give them about a +2 or +1 with the spherical aberration. In fact, there are some patients who I checked are actually quite happy.
Okay.
Works,
And
works
you
well.
said the dominant, you keep it. Do you do always the dominant eye first or
Uh,
the nominant?
I
Is there
see
anything you do?
dominance, though the concept is well established, I find dominance shifts. There have been studies wherein the dominance shifts. So, yes, if you are right-handed, you tend to be dominance in the right eye, but dominance in terms of first really doesn't make a difference. But I prefer to keep it just myopic because see, in a hyperopic, they cannot accommodate for distance and near. So then you're really in trouble. But myope, you can just say that once the capsular contraction occurs, there is a bit of hyperopic shift anyway. I think that's a good question. We do get patients sometimes. You have to tell them that distance vision will always be better in the first eye, which is the monofocal eye. You are giving them that spectacle ad inside the eye. So tell them not to compare.
Thank you.